Bismillahirrahmanirrahim. Our case today very interesting. Preterm, 28 weeks, extremely birth weight, admitted to NICU due to severe RDS. The baby connected to mechanical ventilation and received 2 times doses of surfactant, and also started on caffeine citrate to facilitate extubation and prevent apnea prematurity, as well as TBN fluid and protocol feeding, septic cup taken, and started antibiotic. On day 3 of life, during daily evaluation and assessment in the morning round by Dr. Adina, there is wide pulse pressure and pounding pulse, continuous machinery murmur, and hyperdynamic circulation. This is called classic manifestation of the PDA. Classic manifestation of the PDA, for which cardiac evaluation done, chest X-ray, ECG, echo for limb blood pressure, and confirmed hemodynamically significant PDA, for which treated conservative supportive treatment or symptomatic treatment, fluid restricted, and blood transfusion given for anemia, and metabolic acidosis was treated. On day 7 of life, what happened? During again assessment in the morning round, still there is difficulty to wean the baby from the ventilator, and there is persistent hypotension, require inotropic support. This is called what? Non-classic manifestation of the PDA. Non-classic manifestation of the PDA, difficult to wean the baby from the ventilator, and there is persistent hypotension, require inotropic support. So for which cardiologist came and reviewed the patient, echo done, still hemodynamically significant PDA, for which started first course of antiprostaglandin or anti-inflammatory treatment, ibuprofen, because indomethacin not available. Just started ibuprofen for how many days? 3 days, and then clinical assessment and the echo evaluation were done, still hemodynamically significant PDA. Again, second course of antiprostaglandin, anti-inflammatory given for 3 days, and the patient reviewed by cardiologist again after 3 days for second dose of antiprostaglandin or anti-inflammatory, but still there is hemodynamically significant PDA. So the baby received 2 courses of ibuprofen or antiprostaglandin or anti-inflammatory for closure of the PDA, but still there is hemodynamically significant PDA. So this is called what? Failure of medical treatment or pharmacological treatment, for which the patient referred to cardiothoracic surgeon for what? For PDA ligation. For PDA ligation. The summary or key points of the case. The summary of the case, the key points of the case. The first, what are the classic manifestation of PDA? Bounding pulse, wide pulse pressure, and continuous machinery murmur and hyperdynamic circulation. This is classic manifestation of the PDA. But what are the non-classic manifestation of the PDA? The resistant hypotension and difficult to wean ventilation. This is the second key point. The third key point, the PDA, it's association, not causation. What does this mean? Association, this is association between 2 or more variable, and causation, this means a change in one variable leading to another. So it will be same mechanism and same pathophysiology. The fourth key points, conservative treatment, supportive treatment, symptomatic treatment in the first week of the life, because possibility of the spontaneous closure is very high. It's very high. What is the meaning of conservative treatment? Symptomatic treatment, avoid liberal fluid. So restrictive fluid. If there is anemia, treat with blood transfusion, and if there is metabolic acidosis, you have to treat it. And the fifth key point, frusomide, diuretics. Avoid frusomide, avoid diuretics. No routine use unless there is evidence of volume overload or heart failure. Why avoid frusomide in the PDA? Because diuretics, it will increase the prostaglandin. What will happen if you increase the prostaglandin? It will open the duct, and also in additional to side effect of the frusomide or diuretics, leading to hyponatremia, hypokalemia, and renal impairment. The 6 key points: the ventilation. If the patient on the mechanical ventilation, you have to increase the PEEP, allow for permissive hypercapnia, and you can use volume target ventilation, or you can add VG volume grantee. The 7 key points: intervention, medical intervention or surgical intervention. Medical intervention or pharmacological treatment, so late better than early treatment. Late better than early treatment. Late, this means after 7 days of life. After 7 days of life. Why late better than early treatment? Because the possibility for spontaneous closure, it will be high, and also it will be visible and safe, and also it will not improve the outcome short or long term. If you will treat early treatment, it will not improve the outcome short term or long term. So the late better than early, because there is possibility for spontaneous closure, and not expose the patient for medication or anti-inflammatory, leading to impairment of the neurodevelopmental outcome, or it will affect the neurodevelopmental outcome. Intervention, PDA ligation, surgical. So PDA ligation indication if there is contraindication for medical treatment or failure of medical treatment. Our patient here, there is failure of medical treatment, 2 courses of ibuprofen given, and still there is hemodynamically significant PDA. So you have to refer this patient for PDA ligation. PDA ligation, there is a scar, we call it surgical scar or cardiac scar. The indication left lateral thoracotomy scar for PDA ligation. For PDA ligation, our patient, the scar in the right side. Why in the right side? Should be in the left side. Why in the right side? Because right-sided aortic arch, where there is right-sided PDA, this PDA actually will ligate it from the right thoracotomy, So supposed to be the scar in the left side, the PDA, and the pulmonary artery banding for complex heart disease, coarctation, PT shunt. It will be, this is indication for left lateral thoracotomy. But our patient in the right side. Why? Because right-sided aortic arch, and where there is right-sided PDA, so this PDA will ligate it from right thoracotomy. But what about indication for right lateral thoracotomy? It will be PT shunt or balloon shunt. What about the median sternotomy? Indication for median sternotomy. Scar indicate what? Indicate 3V. VSD, valvular lesion, ventricle, single ventricle. ومن أحياها فكأنما أحيا الناس جميعا. شكرا، سلام عليكم.